Thank you very much, Basil. We are here as representatives of a working group in the ESC, Cardiology. Why do I speak about diabetes? A first consideration is, just consider, is diabetes a cardiovascular risk? Yes, and if you look at subgroups, diabetes subgroup is always at the highest risk. We could repeat from today, improve it, for example, diabetic patients improved best. First consideration, diabetes is a high risk. But second consideration, is it glucose that makes the diabetic patient more risky? We look at that. If that would be true, then it would be true that glucose-lowering drugs do the best to the diabetic patient, also for his cardiovascular problems. If it's not true, then we should test in trials the diabetic drugs that all reduce glucose, whether they can also do something good or bad in patients with existing heart disease. And this is the important third point. Are they equal, non-inferiority trials, or are they superior? And that's the baseline which I would like to choose for discussion with you, without a discussion, as you know. So going back in history, it is clear that we did not know whether cardiovascular disease improved. Indeed, we had examples that cardiovascular disease was rather increased with the anti-diabetic treatment. And rosiglitazone is one of the examples where we got this impression. The impression was wrong, but the consequence was very good. As we know now, then the ACCORD trial that tried to reduce glucose as much as possible induced more cardiovascular deaths, as we believe in part due to hypoglycemia. And therefore, the FDA and later on the EMA required all new drugs in diabetes to be tested for what, have you said, for non-inferiority or even superiority. And that's the skeleton of our thoughts we have now. I want to focus only on these three fields of innovation that we have already in the present and that will also influence us very much in the future. Let us start with GLP-1 receptor agonists. Time does not allow to go into mechanisms with slides, but GLP-1 is a molecule that is good for insulin production, for glucagon reduction, good for reducing gastric emptying, so slowing gastric emptying, and also good for suppressing appetite. You could say it's a miracle drug. But GLP-1 is a hormone produced by our gut, which has a very short half-life. So if we want to have these effects for longer, then we best produce drugs that have the same effects, but for longer. And that's the basic principle behind. Now, I give you another consideration now. If you look at cardiovascular patients and diabetes, then it is most appropriate to have a good population to be tested. And the population is ideal, I think, if you have 100% patients with established cardiovascular disease. And you see in all the trials we will go through now in some minutes, this is not entirely the case. The leaders are here, EMPAREG-OUTCOME, ELIXA, EXAMINE, and TECOS. They really have had the chance to test specifically glucose lowering and at the mechanism they are trying to prove in cardiovascular patients. Other studies have mixed populations, and mixed populations normally dilute the effect. So let us see what we can see from the trials. Now we go into this first group, and here, Excel, I don't read these slides. You just look at what is done, what is the inclusion, what is the number of patients, what's the follow-up, and what's the endpoint. And you see that here for another one. And just let us summarize. This is completed Excel, and we show the results soon. The next one, and this is the title of all these talks, what's coming on. The next one will be this ITCA with the same substance, you see. Okay, then we go to ongoing trials. Further ongoing trials, a new molecule, and you see again what is the inclusion, number, follow-up, and endpoint is quite similar in all these trials. Why? Because we want to know, is it non-inferior or is it superior to the past therapy we had? So here we have to wait for 2019, and dulaglutide, a further molecule from this class, we have to wait also for the same year. Good. If we now take together this first of 3 groups of fields of innovation, then we see we have 2 positive trials. If I may focus here, it's the SUSTAIN and the LEADER. The semaglutide is not in the market, so we omit that for a moment, and we have 2 neutral trials. The Excel is the one I just showed you that has been completed this year. Perhaps you will also like to see that there is a little HbA1c reduction, not surprising in diabetes trials, and there is some weight reduction, which is probably a very good side effect of this type of drugs. Okay, the question now is this, because we have here 2 positive and 2 neutral ones, is this a proof for no class effect? No, it's not. We have different populations, we have different plans of intervention, and we have different results. Maybe there is no class effect, but probably it's just the difference between trials, not between substances. Okay, then the leader here has the right name. Liraglutide is the most prominent one. And to be concise, it is always important in these diabetes trials to compare or to focus on the comparator. What was the comparison? The comparison is between this is an injectable drug, as all GLP-1 receptor agonists, versus an injection of a placebo, but on the background of the best available diabetes therapy. And that's, I think, also for the whole session very important. In lipids, we go further after statins. In acute coronary syndrome, we have had aspirin for a long time, and you have just heard we just want to do more, and now also consider a bit is perhaps less better. Anyway, this is liraglutide, or liraglutide as many say, versus placebo on the basis of the best treatment available. And if you look at that, it is quite a remarkable progress that you have in cardiovascular mortality and hazard ratio of 0.78, so a 22% risk reduction. Superiority, a miracle we thought for 5 years ago. And if you look at another endpoint, which may be more important for you, it's still total mortality. Of course, it's always diluted, total mortality. It's brought about by the cardiovascular mortality, and it's still significant. So this is the LEADER trial. And that was the end of the first group of substances, GLP-1 receptor agonists. Now, GLP-1 is decayed in our blood by the DPP-4 enzyme. So one could say one could also just use the intrinsic GLP-1 and reduce its catabolic rate. And this is done by DPP-4 inhibitors, and this has the advantage that this drug class can be taken orally. And I make this very short because the published DPP-4 trials we have at present clearly show that we have studied a lot of patients, you see here. But to make the story short, we have shown non-inferiority for all these drugs, very consistent picture, but we have no cardiovascular disease benefit. So this is quite clear. DPP-4 inhibitors are non-inferior, but not superior, in comparison to the some of the GLP-1 receptor agonist trials. Now, what you will be interested perhaps is this story on DPP-4 inhibitors now finished. No, it is not. We have a very important substance, I think, linagliptin, still studied in these 2 cohorts, randomized clinical trials, and you see, again, quite large study. Follow-up is 400 weeks, endpoints are cardiovascular, and the other one is very similar. So I just summarize here. Next year we will have Carolina. This will be a very important study because it has a very good prerequisites to have a superiority result. And the other one is Carmelina also next year. So for the DPP-4 inhibitors, you remember 1 minute ago, we have non-inferiority. These are the market leaders now in diabetology in Europe. So our cardiovascular patients, if they have diabetes, most of them will have a DPP-4 inhibitor. Now, the third and last group of compounds I would like to show you is the SGLT2 inhibitors. What do they do? Completely different to the first two I showed you. GLP-1 agonists, the GLP-1, the good molecule should stay longer in the body. We make new compounds. DPP-4 inhibitors, we use our own molecule to stay for longer because we reduce the catabolic rate. Now we look to the kidney. We have there a transporter for glucose and sodium, a sodium-glucose transporter, SGLT2. The number 2 says this is one of two molecules. This is the important one that is responsible that we don't excrete glucose in our urine because it takes back the glucose from the filtrate, glomerular filtrate. Now, if you inhibit that, you get glucose out of the body, and this is very interesting. You lose glucose, you lose energy, and that was the idea behind this group of drugs. And I think here, the miracle study is this one. It's called EMPAREG-OUTCOME. We were in this trial, and I just show you here in a bit bigger font what was there. The patient population, not so much different from the trials you have seen before. What was the randomization? It was 2 dosages of EMPA versus placebo. Placebo, what did we say before? We must remember that. Follow-up was short, and this was the endpoint. We have to be concise. It's empagliflozin, a tablet, in addition to our standard glucose treatment, versus placebo, so an additional tablet, but it's the best diabetes treatment we have. This is very important to remember. And now I just show you the outcome Kaplan-Meier plots, and the first one is for the primary endpoint. This is MACE, and you see this is a clear result, but it's not so much impressive. It's significant for superiority. Just keep this picture in your mind. The next one is, this shows us that the number needed to treat is not very high, in addition to the best diabetic treatment we have. If we now go on and look at this line, this is much more pronouncedly different between EMPA and placebo, and this is cardiovascular death. So this is a very impressive result. It's consistently more and more reduction of cardiovascular death. So you see here, total mortality is the next one. Also, perhaps here I may focus on the number. 0.68 is the hazard ratio. More than 1/3 reduction in total mortality. Never seen before. So, and here now you see the hospitalization for heart failure. And if you remember the other slides, then you will see this separates very early because you have an osmotic diuretic with your body's glucose going through the kidney. So it's, in my mind, it is a double benefit. It's the very soon attained benefit of the reduction of the hospitalization rate because you have a very good diuretic. And the other ones you have seen, it's the pronounced and sustained long-term mortality benefit. Okay, you see here very clear. Now there are other studies in this field. Canvas has just been completed and has had the bad result of increased amputation rate, although other endpoints were quite good in that study. And the DECLARE which uses dapagliflozin and which is the most used SGLT2 inhibitor in the world, is expected for 2019, and only then we can say is an SGLT2 inhibitor the same as another one. If we just now look at Canvas, we see, and I think we can be here quite quick. This is a smaller study. I showed you before there is a problem with amputations, but many other things were quite good here, and it is completed, and Credence is the next one that is expected for 2019. So I think, and just Canvas had a 3-point MACE reduction, but no death reduction, no all-cause mortality reduction. So it is not quite clear whether we have here a group effect. Canvas supports the main findings, I should say, of EMPAREG-OUTCOME. There is another substance here, Canagliflozin, which is also tested from a different company, and this is expected not so soon. So I think we are in a very active field with the SGLT2 inhibitors, very much inspired, I think, by EMPAREG-OUTCOME. So if you like football, for example, and you look at the scores you have by these substances I showed you, then there are 3 leaders, I think. The first is EMPA. It reduces the MACE, the cardiovascular death, all-cause mortality, heart failure, hospitalization, and also a deterioration of kidney function, which I could not include in this short talk. Liraglutide, 3 scores, and Canagliflozin had only 1 of them, but you see here the 14% MACE reduction is very consistent with the one in empagliflozin. If you want to look at those data like on a traffic light, you could say, well, the greens are the good results, and you see if you count the green lights, then EMPA-REG is very good, LEADER is very good, Canvas is supporting EMPA-REG, Sustain is supporting LEADER, and from the DPP-4 inhibitors we had 1 red light that was hospitalization for heart failure with one of the substances which is not used anymore. So in conclusion, we can say we have benefit for coronary artery disease with 2 substances and for heart failure with 1 substance. And this is just a timeline. These studies have come, and just from the last row, you can say, well, this is clearly a very good development. Diabetes is very important at the moment and also in the next few years. With that, I would like to finish and say, well, we have now superior drugs. We know that diabetes, the very high-risk population, can be treated better, and we strongly believe this is not only because of glucose lowering, but mostly by SGLT2 inhibition, or perhaps by the other group of drugs that go along with inhibition, with activation of a good molecule we have in our body. Thank you very much for your attention.